as you are rightly quoted, wisdom is the continuous efforts, lifelong efforts to acquire it. So for that, we need to learn something new every day. This is great sayings that for every action, there is an equal and opposite reaction. That means for every systole, there has to be an equal and opposite diastole. Without any good diastole, there will not be any good systole. So before actually we should proceed to the actual discussion about the diastolic dysfunction, let us see this case, which we have encountered a few years back. A 70 years female posted for the radical mastectomy. She was diabetic hypertensive with grade 1 dyspnea on exertion. Investigation just minimally raised creatinine and good ejection fraction. So heart-wise and apparently she looks okay. So general anesthesia was given with endotracheal tube. Intraoperative, she is fine except few episodes of the hypotension managed with the fluids and few anotropes like mefentenolol. So during extubation, some delayed extubation was there, but patient extubated well and so shifted to the recovery room. So within an hour, there was a call, but the patient is not doing fine. She is restless, labored breathing, saturation is reduced. So we go on there and see that patient was in frank failure. But engorged neck vein, scrapes, pulmonary edema, and the blood pressure was not low, it's high. So immediately we re-intubated it, shifted to ICU and searched for the cause because patient was apparently looks okay, lung-wise, cardiac-wise, and otherwise, and intraoperative also. So we done an all investigation, including UDICO, and we found that still the systolic left ventricular ejection fraction is good. But there was a grade 3 diastolic dysfunction like this. So we reviewed the UDICO, what was there in preoperative period, and we see that there was a good ejection fraction, but there was a grade 2 diastolic dysfunction and with a mild pulmonary hypertension, which was turned to grade 3, that is severe diastolic dysfunction. So it is when we see that there is a good ejection fraction, we routinely forget to see that what others in the report. And we feel that good left ventricular ejection fraction means good heart, but this is a wrong assessment. And because of that, we easily overlook the left ventricular diastolic dysfunction. And the prevalence of this diastolic dysfunction is really very high. It is almost every fourth patient or an individual in the society is having some or other form of the diastolic dysfunction. And it is said that after the years of 70, everybody has a diastolic dysfunction. And nearly 50% of all the cardiac failures are because of the diastolic dysfunction. So it's a great number. And the most important is that the prognosis and mortality is same as systolic dysfunction. So the grade 3 diastolic dysfunction with good left ventricular ejection fraction and the left ventricular ejection fraction of 30% having the same mortality, but we don't realize it. And as you compare with the normal population, mortality is 4 times normal with the left ventricular diastolic dysfunction. And it can happen with a good left ventricular ejection fraction that is called as a HFpEF, that is heart failure with preserved ejection fraction. And also this diastolic dysfunction can occur with the reduction in the systolic dysfunction. So it comes with all forms. So we have to just identify it. So before actually proceed to the diastolic dysfunction per se, let us brush our knowledge of physiology. This is very important to understand the pathology. So when diastole starts, the aortic valve closes and the mitral valve still closed. So the left ventricle dilates as a closed structure. So there is a sudden fall in the intraventricular pressure. Then the mitral valve opens and there is a gush of blood from the left atrium to the left ventricle. And that is because of the LV dilates actively. And this feeling is called as the early rapid filling, which is responsible for around 70 to 80% of the maximum filling of the left ventricle. Then there is equalization of the left atrium and left ventricle or pressure in the latter part of the diastole. And lastly, there will be atrial contraction. And then there is a second gush of blood from the aorta to the atria to the ventricle, which is responsible for around 20 to 30% of the left ventricular filling. So left ventricle get filled during 2 phases. One is the early rapid filling, which is a major filling, and lastly, because of the atrial contraction. So when we put a cursor across the mitral wall above the 2D echo-Doppler, there will be two waves. One is E wave and another is A wave. You can see this E wave and A wave. That corresponds to the early rapid filling and lastly the atrial contraction. So which are the factors responsible for the left ventricular filling? The most important factor is the rapid suctioning of the left ventricle because of the active dilatation or relaxation of the left ventricle. So we think that the left ventricular filling is actually a passive process that will just get filled because of the back pressure or back flow from the left atrium, but it is not like that. The majority of the left ventricle filling is because of the active dilatation of the left ventricle, and which is responsible for the early filling, and the vasoelastic properties of the left ventricle, which is a passive relaxation, which is responsible for the late filling of the left ventricle, and also the volume within the left atrium, that is a preload, and the atrial kick is also responsible for the left ventricular filling. So the ventricles and the supraventricular factors and the pressure gradient between them is responsible for the diastolic filling. So whenever there is a deranged either relaxation or the compliance, that is the elasticity of the left ventricle, there will be a problem in the left ventricular filling, which leads to the increased back pressure, that is left atrial pressure. So for the filling of the left ventricle, we need a higher left atrial pressure. And this inability of the ventricle to fill at low atrial pressure is called as a diastolic dysfunction. So this dilatation, the relaxation, active relaxation of the left ventricle is not a passive. So it requires energy in the form of ATPase. So you know that for the contraction of the left atrium and left ventricle, there is an actin-myosin contraction is there, which requires calcium. And actively this calcium is taken away from this actin-myosin filaments, and it is sequestered back into the sarcoplasmic reticulum, which requires energy, ATPase. For that, we call it as an active relaxation. And whenever there is ischemia to that part, because of whatever may be the reason, this active relaxation is reduced. So whenever there is ischemia, the diastolic dysfunction has to be there before any systolic dysfunction. So whenever we see that the patient is having ischemia with reduced ejection fraction, the diastolic dysfunction has to be there with the various forms in it. So second most common cause is the hypertrophic cardiomyopathy. So there is a thickened left ventricular wall, which reduces the active relaxation, also seen in aortic stenosis and other forms. And second most important cause of the diastolic dysfunction is the reduced compliance. That means change in the volume inside the ventricle per unit change in the pressure, as if like a balloon. Consider the balloon, elastic balloon, and when we pour the water inside the balloon, the amount of water that balloon takes depends upon the elasticity of that balloon. If the balloon is more elastic, it will take more water. The same way, the left ventricle, if it is more elastic, it will take more blood from the left atrium, and the next ejection will be good. So it is responsible for the late filling of the ventricle. So it is very common in advanced age and a long-standing hypertension. So you have seen that in long-standing uncontrolled hypertension, it causes impaired relaxation also and impaired compliance also. So in old age with uncontrolled hypertension, the diastolic dysfunction has to be there inside the patient. So in other causes are the myocardial fibrosis, infertility disorders, and the other causes from the outside are the pericardial constriction, effusion, like that. So these are the common causes. Just now we have discussed the ischemia, hypertension, aging, obesity, stenosis, and other some uncommon causes. So why we are worried about this? So whenever there is diastolic dysfunction, it causes increased back pressure, increased left atrial pressure. So increased LA pressure. So there is increased pulmonary venous arterial pressure, which leads to a pulmonary hypertension, which leads to the right ventricular increase in afterload, then right ventricular failure, which again compresses the left ventricle and leads to the left ventricular failure, that is congestive heart failure. So because of that, we are worried about, and this is a vicious cycle. So the left ventricle fails, and again it then right ventricle fails and it compresses the left ventricle and causes a congestive heart failure. The two different terminologies are there: the diastolic dysfunction and diastolic heart failure. The diastolic dysfunction is clearly purely diagnostic terminology. That means there is a impaired relaxation that we diagnose on a 2D echo, and on the top of that, if there is a clinical symptoms of the heart failure, we call it as a diastolic heart failure. And 2D echo is a very effective diagnostic tool to detect the diastolic dysfunction. We see the left ventricular inflow through the mitral valve and the myocardial movement during the diastole are the two important effective tools to diagnose the diastolic dysfunction. And along with that, we also see that the other factors, that is left ventricular hypertrophy, left atrial dilatation, increased volume of the LA, then the pulmonary hypertension that we diagnose with the tricuspid regurgitation, that we all see. In a transthoracic echo, we put a echo probe on the apex of the left ventricle, and we see that the gush of blood from the LA to LV, that is towards the probe, that gives the positive deflection. There are two positive deflection. One is E, that is for the early filling, and second is A, that is a late filling. And second is the tissue Doppler, which measures the myocardial movement velocity. So during contraction, the base of the heart moves towards the apex. So that will give the positive deflection. And during diastole, the base moves away from the apex. So that gives a negative deflection. So the waves are E prime and A prime. So you can see in this, with the cursor, this Doppler beam is placed just on the mitral wall, and we see the inflow velocities of the blood through the pulsed wave Doppler. And in the second figure, you can see we put a beam on either on the medial or lateral side of the mitral wall and see the myocardial movement, that is called as tissue Doppler. And with this, we diagnose the 3 grades of diastolic dysfunction. The grade 1, which is mild, which is just impaired relaxation. Grade 2 is pseudonormalization. We'll see in the next slide what is pseudonormalization. And grade 3 is a severe form of the diastolic dysfunction called as a restrictive feeling. So here, the first upper slide is of normal mitral wall inflow. The pulse wave Doppler is placed just on the mitral wall, and we see that the early rapid filling, that is E wave, and the A wave is because of the atrial contraction. So this is the pull pathology. Pull means the left ventricle sucks the blood, which acts as a pump and get the blood from the LA. In a grade 1 diastolic dysfunction, there is an impaired relaxation of the left ventricle. So the pulling of the left ventricle is reduced. So this E wave is reduced. But there is a compensatory increase in the left ventricular filling during the atrial contraction. So A will be more. So E will be less and slowly or delayed E wave, and A will be bigger. So what is the importance of that? This is, I have mentioned, this left side is a normal, E wave is more, and A wave is small, where in a grade 1 diastolic dysfunction, this E wave is small, and there is a delayed filling. So these patients don't tolerate the tachycardia because the diastolic time has to be there to fill the left ventricle, and A wave is bigger. So this patient don't tolerate the rhythm other than the sinus. Suppose this patient goes into AF, they don't tolerate it because the A wave, the atrial kick, is very much responsible for the filling of the left ventricle in grade 1 diastolic dysfunction. Now the relaxation get impaired, and the suction effect of the left ventricle is reduced, and the left ventricle is get filled because of the push from the left atrium, and that is because of the increased back pressure. This increased back pressure is a physiological adaptation, physiological compensation to increase the blood flow across the mitral wall. So again, there is an increase in A wave, and A wave is reduced because during atrial contraction, already there is a increased left ventricular pressure. So again, E wave is raised and A wave is reduced, which is more than A. There is a E by A, and it looks like a normal. So it is called as a pseudo-normalization. And in severe form of the diastolic dysfunction, that is called as restrictive, or only the left ventricular filling occurs only in the early phase of the diastole. So there will be very high E wave and short E wave, a long gap, and a very minimal or no flow during the atrial contraction. So E by A is more than 2. And this is a push pathology from the left atrium. So and the second assessment is through the tissue Doppler. That means we are assessing the left ventricular myocardial movement. And this linearly reduces as the diastolic dysfunction occurs. So there is no biphasic wave seen here. The E prime is the early rapid relaxation phase, and the tissue Doppler shows if it is more than 8 or 10 centimeter per second, it is a normal velocity of the left ventricular diastole, and it is linearly reduces as the diastolic dysfunction increases. So in nutshell, the E by E prime, that means E is blood flow velocity divided by the E prime is myocardial velocity. If this is less than 8, this is good, a normal heart. But as it increases and goes above 10 and particularly above 15 in the severe form, it says that there is an increased filling pressure, and it is a severe form of the diastolic dysfunction. So when such patients is posted for surgery, how to assess this patient? The first thing, if patient is not overtly diagnosed, that is not in frank failure, so we have to predict that this patient may have underlying diastolic dysfunction. So we have to have a high level of suspicion to diagnose these patients, particularly in a old lady having uncontrolled hypertension, diabetes, myocardial ischemia, or previous history of diastolic dysfunction, or obese patient, a recent weight gain, some or other form of renal derangement is there. So we have to suspect that this patient may have a diastolic dysfunction underlying. We have to investigate these patients. And the clinical features are, the first and foremost is the chronic fatigue syndrome. This patient will have dyspnea on exertion and having a very low MET value. And the most important finding we get is the resting tachycardia, because this patient have a increased resting sympathetic tone. So this is very important for us. So whenever we induce the patient or give the anesthesia, this sympathetic tone reduces, and there will be sudden deterioration in the hemodynamics. So always consider this patient having a higher resting sympathetic tone. So there will be a uncontrolled hypertension or resting tachycardia, and in a frank failure there will be a hypoxia, nocturnal dyspnea, tachypnea, and other signs of failure like raised JVB, ankle edema, Krebs, Ronca, and like that. This slide I have deliberately put because the systolic heart failure and diastolic failure, I have a same clinical scenario. Just now what we have discussed. The only difference is the heart cannot fill in diastolic dysfunction, and in systolic function, the heart cannot pump. And another important difference is basically in failure, the BNP is very much raised in systolic failure, but not much raised in the diastolic failure. And for us, the most important is the treatment is not much supportive in favor of the diastolic dysfunction. But we all know that the treatment is very much evident in a systolic heart failure. So if this patient comes to you, you have taken the history and the investigations are come in front of you. So in such patients, don't accept the low hemoglobin, optimize it. If in major surgery, you can raise it more than 8, 9, sometimes 10 if vascular surgery is there. If KFT is there, suspect that there might be underlying diastolic dysfunction in it. If this patient's having a deranged electrolytes, maybe because of the large use of the diuretics, correct the electrolytes, particularly potassium, because there are high chance of patient going to the tachycardia, particularly in AF, various type of arrhythmias. Cardiomegaly is seen. Whenever there is cardiomegaly, there is a decreased ejection fraction. So if preserved ejection fraction is there, there will not be any cardiomegaly. And prominent pulmonary arteries may be seen on chest X-ray. Echo we have seen in detail. and something about the ECG. This is very interesting. The P is the only wave which comes in diastole in ECG. So the abnormalities of the P wave indicates that there might be underlying dysfunction. The wide P wave, wide and biphasic notched P wave, more than 120 milliseconds, represents P mitrally. That means there is a left atrial enlargement and maybe underlying diastolic dysfunction. And if the pulmonary hypertension is too severe, we see that the tall P wave, that is a P pulmonally. We know that this P mitral and P pulmonally. And suppose this patient of diastolic dysfunction comes to you, you can see that if there is a S1 in V1 and R wave in V6 or 2 and V5, if they combine, they show that more than 35 small squares. That means there is a left ventricular hypertrophy, and also the V1 1 and 3 shows leaving each other. That means there is a left axis deviation. But if you see this P wave, it is more than 4 small squares. That means patient is having a left ventricular hypertrophy with left atrial dilatation. That shows that the diastolic dysfunction is more than grade 2. So we usually miss this P wave, and this is very important to look in a diastolic dysfunction. So if such patient come to you, you have evaluated it. Now, what is the risk of the operation? You have to stratify the risk, and there are a lot of references. So I have simplified this in this fashion. That there is a perioperative risk of delayed weaning from the mechanical ventilation, more use of vasoactive agents, diastolic heart failure, prolonged ICU stay, and mortality is very high in grade 3 diastolic dysfunction. As if we have mortality in severe form of stenotic lesion or severe triple vessel disease, IHD patients, and very less or almost no in grade 1. So we have to grade these patients before we posting this patient for the surgery, and we have to optimize these patients, because the control of the heart rate, pressure, and volume overload reduces the perioperative risk. So we have to control the tachycardia, heart rate. If AF is there, we have to control the rate, and any fluid overload we have to control with the diuretics. And after optimization only, we have to post this patient for the surgery. Now, everybody's hit topic, which anesthesia we should give, either GA or regional, but there is no definitive recommendations on either way. But there are a few interesting studies done on this. If you combine this regional anesthesia, either epidural anesthesia or various blocks with the general anesthesia, the perioperative outcome of the left ventricular dysfunction is very much good, because it reduces the use of inhalation and other agents because of the addition of the regional anesthesia. And for the obvious reason, spinal anesthesia should be avoided in severe form of the diastolic dysfunction, because there is a precipitous fall in the blood pressure because of the sudden decrease in the SVR. So whatever anesthesia you use, our technique should maintain the hemodynamic stability. And for that, the most important we have to manage the volume, rate, and pressure, because there is a very less margin to about this volume, rate, and pressure on either side in severe form of the diastolic dysfunction. Because if you give more volume, there will be a increased back pressure and pulmonary edema and hypertension. On the other hand, if you give less volume, as this left ventricular, feeling depends upon the preload, there will be less stroke volume and ejection fraction. If rate is reduced too much, the same way is a fixed cardiac output status in severe valvular dysfunction form. So if rate is reduced, the cardiac output will be reduced. And suppose rate is increased, this will cause a decreased filling of the left ventricle. So cardiac output will be reduced. Same about the pressure. If the high SVR is there, systemic vascular resistance, so itself will delete risk for the diastolic dysfunction. But if sudden decrease in the SVR occurs, there will be decreased coronary perfusion pressure and causes ischemia, because the coronary perfusion pressure depends upon the diastolic blood pressure minus the left ventricular end diastolic pressure. So the left ventricular pressure is high and diastolic pressure is low. There will be high chance of patient will go might face the myocardial ischemia. So there will be a narrow margin. As the grades of diastolic dysfunction increases, the margin of reduces as the grades increases. So our aim to manage this volume status and the sympathetic stimulation, our focus is on that. And for that, apart from the routine monitoring, the monitoring for the volume status, we need to put an invasive pressure monitoring. We put a arterial line or femoral line for the bit-to-bit monitoring and also for the assessment of the volume status, because the stroke volume variations or the pulse pressure variations, systolic pressure variations will give a fair idea about the relative hypovolemia of the patient. If it is more than 15%, the patient will have a relative hypovolemia. We can give fluids. And if there's less than 13%, we don't give the fluids in these patients. There is a lot of controversy about whether to put a central line or not. But I personally feel we need to put a central line because of the two reasons. One is whenever needed, we can give various inotropes in it directly. And second one, if it's a change of the CP value will give a fair idea about where we are heading towards. For example, we started the case with the CVP of 910 and suddenly there is a hypotension. And now if the CVP is 5, we give fluids. And if CVP is 15, obviously we restrict the fluids and give the other inotropes or like that. So definitely it is helpful, even though many says that it is of a controversial use. And the TE and pulmonary catheter is for the cardiac patients. So the general considerations in the anesthesia is we have to maintain the hemodynamic stability, because the drug per se in general anesthesia will not, or any type of anesthesia will not cause directly affects the diastolic dysfunction. But the process of intubation, extubation, blood loss, we have given the fluid, various noxious stimulus causes sympathetic stimulation, that causes hemodynamic instability, and which worsens the diastolic dysfunction, and in turn that causes a hemodynamic instability. So we have to break that chain. So our aim is general aim is to maintain the rate, pressure and loading conditions, and we have to avoid the hypoxia, hypercarbon acidosis, because which increases the pulmonary hypertension. So this is very important slide. So this is the general consideration. So in a grade 1 diastolic dysfunction, that is just an impaired relaxation, I have told you you can give a liberal fluids in these patients because there is no back pressure, increase in back pressure. There is still a left ventricular section is acting, but less acting. So you can give some fluids. And there is a delayed relaxation. So you need a more time for the diastole to relax. So don't tolerate the tachycardia. And also they are volume dependent. So give fluids, maintain the rate, don't allow the rate to high, and maintain the sinus kick. As you have seen that in grade 1 diastole, if you remember, there is A is bigger than E wave. So the left ventricular filling depends upon the atrial kick. So in a milder form of the diastolic dysfunction, you can give fluids, maintain the sinus is very important, and avoidance of the tachycardia. But as the diastolic dysfunction increases, grade 2, grade 3 particularly, so the exactly opposite management is there. We have to restrict the fluid because they don't tolerate the volume overload. Sometimes you may need to give the diuretics. If hypotension occurs, give vasopressors. Don't give fluids. And definitely avoid bradycardia because these are the fixed cardiac output status patients. So if there is too much of a reduction in the heart rate, it will be net cardiac output will be reduced. So if you don't understand or if you don't want to take home message of anything else, please remember this slide. In milder form of diastolic dysfunction, you can give fluids and maintain the sinus rhythm. But in severe form of the diastolic dysfunction, do not give fluids and avoid bradycardia, and you can give vasopressors, noradrenaline like that. Now, exactly how to do the induction. You know that these patients are of slow and low circulations, very reduced cardiac output, very reserved. They are the old patients. So So the induction dose is very much reduced in this patient, 30 to 50% is reduction. The only half induction dose is needed, and we have to give the inducing agents very slowly. Watch for the effect, because before the effect comes, if you give on too much, it causes precipitous fall in the blood pressure, causes vasodilatations, particularly seen in a propofol. So it is always better to use intermediate in a restrictive form of the diastolic dysfunction. And obviously, ketamine should be avoided because it decreases the LV complex. It increases the pulmonary vascular resistance. And the most important, avoid the intubation response. So do not hesitate to give an adequate opioids in these patients. And if needed, give the lignocaine or esmolol 2 to 3 minutes before the induction. This gives a fair control of the rate and blood pressure during intubation. Maintenance, as such, the relaxants are safe except few relaxants. That is the relaxant which gives a histamine release like atracure and mivacrem, which increases the pulmonary hypertension. The same way, the all inhalation agents are good within 1 MAC. And the nitrous oxide should be ordered because it also causes an increase in the pulmonary pressure. So the baseline recommendation is we have to control the blood pressure. And there is a rule of 70 about that. There is if age is more than 70, we have to maintain the pulse rate around 70, diastolic blood pressure more than 70, and blood pressure less than 70. So how to achieve? Because everybody says that you maintain the blood pressure, this, maintain the heart rate, it's very easy. But I feel that with this, we can manage the hemodynamic stability in diastolic dysfunction fairly well. So after induction, I prefer to give magnesium, 20 to 30 milligram per kg bolus, which is an NMDA receptor blocker, which is excellent co-analgesic and co-anesthetics, which reduces the requirement of our anesthetic agents. And the most important, it suppresses the reflex sympathetic response to a noxious stimuli. That means intermittently rise in the pressure and rate is definitely controlled with this magnesium. And as I already told you, combine the regional versus general anesthesia. Give only, for the epidural, give only the analgesic dose of the epidural. Do not give a full dose of epidural because that also causes a fall in the blood pressure because of a painful hospitalization. So the analgesic dose in the epidural and in the block plus GA. And if at all still not under control, you can give a dexmedetomidine, which is central acting alpha-2 agonist. It fairly controls the pressure and rate. And with this, we can control the hemodynamics. And if at all, we have various drugs to control the hemodynamics in either way. For example, if there is a rate is raised, we have a smaller, which is short acting. So you can give in a bolus form 0.5 to 1 milligram per kg. You can add an infusion, but bolus is sufficient because meanwhile you can correct the basic pathology. If the blood pressure is high, you can give immediately the head of position reverse tendinometers, diuretics, and few drugs. That is a NTG in a low form or a calcium channel blocker like a dilzin can be given. And if blood pressure becomes low, immediately do the triangular position, that is a head low position, which gives a fair idea whether patient is having a relative hypovolemia. That this is actually a test and a treatment also for the hypovolemia. If patient is becoming better, patient may need volume. If worsens, the volume is not the solution. So again, do the head up position and give the phenylephrine or noradrenaline like that. So, but the best combination is a low dose of the nitroglycerin along with a titrated form of phenylephrine or noradrenaline. So vasoconstriction and vasodilation in a combination works in a better fashion because it preserves the vascular distensibility, is at the same time doesn't allow to reduce the both preload and afterload. So it maintains the stroke volume well. If you combine this low doses of the nitroglycerin and noradrenaline, but it is better action in the combination rather than the individual action. So another important drug in the diastolic dysfunction, there are two drugs. One is milrinone, another is the levosimendan, which directly acts on the diastolic function. That is called as lucinotropic action. So contraction is the inotropic action and good relaxation is a lucinotropic action. So this is the inodilator that is causes increased contraction, lucinotropic that is good relaxation, and vasodilatory. So there is a good systolic and diastolic function occurs with the milrinone. And another drug is a levosimendan. It causes itself sensitize the contractile element of the calcium. It's good inotropic. It is also a vasodilator. It helps also maintaining the good systolic and diastolic function. So another important hurdle, the last hurdle is for us is the extubation. Because if you extubate when patient became awake, it causes adrenal surge and causes hypertension and tachycardia, which is also deleterious. And if you extubate very deep, that also may cause hypoxia, hypercarbia, and causes a pulmonary hypertension. So what to do? So we have to prepare the patient for the extubation. So how to prepare? So during the last part of the surgery, or when the surgery about to finish, we have to restrict the fluids. If sometimes needed, diuretics, give good analgesia through the epidural or blocks, do the head-up position, avoid the extubation response, go the small or like that, and then extubate patient slowly. And if patient doesn't allowing the extubation, not maintaining well, do not hesitate to shift the patient to the ICU with the tube. Optimize there and then extubate, because there are a lot of mishaps happen during a post-operative period. In diastolic dysfunction, mishaps are more common in a post-operative period than the intraoperative period. And in the post-operative period, the diastolic heart failure get precipitated because of the hypoxia, other than the sinus, shivering, anemia, and all electrolyte imbalance that we have discussed. And if it happens, we have to manage with the whatever the factors, the precipitating factors, we have to correct it. We give the oxygen. Oxygen is not just an air, it is a drug which causes a pulmonary vasodilation. So in any during the intraoperative and post-operative period, we give continuously oxygen to this patient till patient becomes stabilized. And if needed, we reduce the preload, that is reverse channel position, diuretics, nitrates, and other drugs if needed for the treatment. So my conclusion is that diastolic dysfunction is not an uncommon finding. It's very common. Every fourth patient will have a diastolic dysfunction, and which is easily missed, and particularly whenever there is a good left ventricular systolic physician. For that, we need a high level of suspicion to diagnose the diastolic dysfunction in high-risk patients. Mortality is high as a systolic failure. The assessment of the diastolic dysfunction of its various grades is important to plan the perioperative. And this is very important carry-home message, is that whenever there is a grade 1 diastolic dysfunction, there is impaired relaxation, you can give fluids, maintain this sinus rhythm, and avoid tachycardia. And in a severe form of the diastolic dysfunction, it's called as reduced compliance, restrict fluids, give vasopressors, and avoid bradycardia. And continue this monitoring in a post-operative period, because the mishaps are more common in post-operative period than the intra. Thank you.